Okay, so in Module 10, what we're going to do is tackle obsessive compulsive disorder. We're going to talk a little bit about what it is in regards to its symptoms, and then also how do we go about making diagnosis with this. So even though it should be noted that this is in the anxiety disorders chapter, and in the earlier DSMs was actually considered part of an anxiety disorder. Obsessive compulsive disorders and some of their related ones are no longer considered an anxiety disorder per se, because they have some unique characteristics that kind of go beyond just anxiety. So we'll find out about that here in a little bit. So first, let's talk about the symptoms of obsessive compulsive disorder. So first, you have obsessions. And when we talk about obsessions, these are repeated, unwarranted, intrusive cognitive events in the forms of thoughts or images, urges, and they're often nonsensical and involve something socially unacceptable or kind of horrific. Now, it's important to note that obsession and obsessive thinking is distinguished from worry in two different ways. So, obsessions usually are experienced by a person as being that nonsensical, whereas the worries are often triggered by problems in everyday living. So, worries are more practical, as in, yes, I can see what you're worried about. Obsessions, they don't seem to make any sense in the day to day experience of the individual. And then also the difference between obsessions and worry. The content of obsessions usually involves those themes of something that's socially unacceptable or horrific, and you don't see that in worry. So it's not just the intrusive quality of the thought that makes an obsession, but it's also the unwanted nature of the thought. It's not the fact that you can't stop thinking about something, it's also that you don't want to stop. I mean, you want to stop thinking about something. A person with full blown obsessions is going to be unable to ignore or dismiss them. And they're going to be prone to interpret them as meaning that they are a terrible person or that someone who might actually act on or the urge to say harm another person. So you can see where the obsessions can be quite disturbing for the individual who's experiencing them. So if you have these obsessions for a long enough period of time, then you may go ahead and get into compulsions, which are these repetitive acts, behaviors, or mental acts, and they're done to reduce the anxiety created by the obsessions. Hence, the obsessions usually create the compulsions, and the compulsions help satisfy the anxiety created by the obsessions. So you can see here there are some very familiar, similar kind of common forms of compulsive behavior. You see cleaning awfully frequently. It's usually associated with an irrational fear of kind of contamination, and it really bears a strong resemblance to certain phobias that we've already been talking about. You also have checking being a very frequent form of compulsive behavior. And this usually represents an attempt to ensure a person's safety or safety and health of a friend or family member. So, really, the most common forms of obsessions, things like immoral thoughts, thoughts about being contaminated, exposed to illness, unwanted sexual and religious thoughts, and thoughts about harming other people, all, as you can tell from that list, pretty damaging and certainly disturbing. Okay. Usually, the compulsions we're viewing as a problem of diminished control. So people can't stop doing them. And many times the individual considers the actions themselves as senseless and irrational. So the fact of cleaning, like washing hands, that's one of those classic types, in that you have to wash hands until you feel clean. So you may wash your hands 10, 15 times. And individuals will know that they don't need to wash their hands 10 to 15 times to be clean, but they can't stop until it feels right to stop, that they've done it enough times or with enough perfection. And that gets into the compulsive aspect. So when you have these obsession and compulsions, what's the dividing line between more average, typical behavior and then going into a full-blown disorder? So first, you have to have the presence of an obsession or a compulsion. I mean, obsession and compulsions. Okay. So a person has to attempt to ignore or suppress or neutralize the obsessions in a time consuming way. So, in other words, if they are spending more than an hour a day with their obsessions and that it's disrupting significantly or causing significant distress, then we would say yes, that is probably an obsessive or compulsive kind of diagnosis. And the level of self awareness in regards to the obsessions and the fact that they are not rational is one way in the DSM they differentiate. So a person can be classified in one of three levels and insights about their obsessions. First is they have good or fair insight. In other words, they understand that the belief are either definitely or probably not true. So the beliefs they have that they're dirty or they're infected with the latest disease and that they are going to infect everyone else. If they realize that they probably are not, that usually shows good or fair insight. Now, poor insight, the person would think that the beliefs, the obsessions that they have are probably true. And then absent insight, or even in delusional beliefs, the person's now completely convinced that the OCD type beliefs that are leading these obsessions are true. Okay. So I think a fair number are in that good or fair insight category, but obviously there's a much more significant and negative prognosis with those that have poor or absent of insight. So what we're going to do in Module 11 is talk about related obsessive compulsive disorders. They aren't obsessive compulsive disorders, but they have several characteristics that are consistent kind of with OCD. So they kind of put them all together here. So we'll go ahead and highlight some of those in Module 11.